Hi guys, welcome everyone to session 3A, or yes, 3A, supporting statewide telehealth initiatives. My name is Matt. You know me from the crazy technological chaos that happened this morning and is currently happening right now behind the scenes. This is a group of people from Massachusetts and a few other states that we have talking about initiatives, and they are excited to get started and share some slides with you. Before we do that, we are obligated to let you know, as always, that this session is being recorded for posterity, and it can be viewed back on the Attendee Hub or on the TASK website sometime next week. Keep your mics muted unless you plan on speaking. If you speak, obviously unmute yourself, turn on your camera so we can see who's speaking. That's usually helpful. Other than that, you're more than welcome to use the raise your hand option on the reactions, or you can type a question in the chat box and we will make sure the speaker knows to answer it if that's what you are more comfortable with. Let's see here, make sure I got everything. Yeah, I do believe that will be it. And I'm going to turn things over to Nicole Clement, who will introduce our speakers for today. Nicole.
Yeah, hi everybody. I'm Nicole Clement with TASK. I'm one of the program specialists here. So the learning objectives for this session are, upon conclusion of the session, participants will be able to outline how some FLEX programs support telehealth projects for critical access hospitals, and rural EMS agencies, discuss lessons learned from FLEX telehealth projects and best practices during the pandemic. Our speakers today are Ronnie Rom. Ronnie is the Rural Hospital Program Coordinator for the Massachusetts Department of Health, State Office of Rural Health. She has co-created and led several statewide rural health networks. Prior to that, she helped develop and then directed a national preferred provider network. Adam Delmolino leads the Massachusetts Health and Hospital Association initiatives regarding telehealth, including convening TMED, the Massachusetts Telemedicine Coalition. Adam's responsibilities also involve post-acute care and care transitions, care management, rural health care, pharmaceutical innovations, climate change, and energy issues. And previously, he served as the Massachusetts Hospital Association Director of State Government Advocacy. Akriti Bombi, hopefully I got that right, contributes to the development and advocacy of healthcare policy and regulations to support Massachusetts Health and Hospital Association members and the well-being of their staff and patient populations. Previously, she served as Chief of Staff for Massachusetts State Representative Marjorie Decker and the Committee on Mental Health, Substance Use, and Recovery. She's a graduate of the University of California, Davis, and Harvard Graduate School of Education. Then we have Abbie Parmenter. She is the FLEX coordinator at the Florida Department of Health and has been there for a couple of years now. She has a Bachelor's of Science degree in psychology from Florida State University and a master's in public health, also from FSU, which focused on rural health and epidemiology. She previously worked at an outpatient physical and occupational therapy office. Lela Shepard became the director for the Office of Rural Health in March 2019. She has over 10 years of public health experience, most recently as a project manager for healthcare preparedness coalitions and ESF8 situation unit leader in Hurricane Michael. Prior to the department, Lela worked for several national nonprofits in the areas of communication and organizational development. So with that, I think I will turn it over to our speakers.
Hi, I'm Ronnie Rom, and I'm the Flex and Ship Coordinator for Massachusetts. And I wanted to just give a few words of background before handing this part of the session over to our Mass Health and Hospital Association. And they're going to talk about their statewide telemedicine coalition. But prior to the pandemic, our state was significantly behind in telehealth, especially in relation to reimbursement. And while our Flex program isn't financially supporting the work that the Hospital Association is going to be talking about, the Hospital Association is our longstanding partner, along with Stroudwater Associates in many things, but in particular in our Rural Hospital CEO, CFO forum. And during the pandemic, our forum met weekly. And it was a really important opportunity for us, for the hospitals, who also, many of them had rural health clinics, to give their input about needs and concerns around telehealth, and then to also get firsthand from the Hospital Association the insights, strategies, and the long-range vision and planning going on the ground on a weekly basis around telehealth. It was, our state is really urban-centric, so having that kind of connection for our rural providers was really a gift. And while we do have some other telehealth work going on in other parts of our state office, we thought that this was the most Flex-related and something that might be of interest to others about the process of how the coalition was developed and what lessons have been learned from it. I just wanted to give some really brief background about our state, especially as it pertains to rural telemedicine. Did I mention that our state is urban-centric? It's often known for the Boston area to the east, but our rural communities are focused in the western and north and south central parts of the state. We also have 2 islands that are 7 and 30 miles out to sea, and each island has a hospital, and each island also has year-round populations of 10,000 and 16,000 that expand to 60,000 and 100,000 during the summer months. And about a quarter of the year, those islands are challenged by weather accessibility. And then our state population now is almost 7 million, and about 10% of that population is rural. So that's roughly equivalent to the size of a small state. And as with many other rural states around the country, our state borders right on the rural communities of other states. So Vermont and New Hampshire to the north, New York to the west, Connecticut and Rhode Island to the south. And that not only compounds the rurality of our communities in Massachusetts, but it also brings up issues of multi-state delivery of services for telehealth. We also have rural parts of our state that are constellations of small, under-resourced communities, and together as a group, they are apart from population centers. And a lot of times they end up having to lean on each other too. And those areas of the state are the ones that are the most challenged around broadband and cell phone access. Either they don't have any, or they don't have very much, or it's unreliable, or it's unaffordable, which is almost the same as not having any or not having very much. And then lastly, our state, like so many other rural states and rural parts of states, are challenged with disproportionately aging populations, high levels of chronic disease and behavioral health and substance use, lots of gaps in services, and then all of that is compounded with transportation challenges. So I'm going to hand it off to Adam and Akriti to talk more about their experience with their wonderful work with the Statewide Telemedicine Coalition. Thanks.
Oh, thank you very much, Ronnie, and thank you everyone for allowing us to present to all of you today. I'm proud to join with my colleague Akriti, who is really my partner in crime in leading the Telemedicine Coalition here in Massachusetts. It's named TMED, and you can see the swanky graphic that we had put together to kind of brand ourselves here in Massachusetts. And I think that's one of the things that's been kind of really important and helpful as in terms of as we've kind of developed this coalition over the past 7 years, I think it is now, that we've been working on this coalition. And it's been really important and critical for the expansion and the advancement of telehealth here in Massachusetts. The real goal, and it's a very simple goal, but it allows for a lot of broad and allows for a lot of flexibility, is to advance and expand access to the use of telemedicine in Massachusetts. The members of our coalition are providers, but also consumer organizations, technology providers, and telecommunications associations, which has been really important and helpful in terms of getting the word out, and also thinking broadly, as Ronnie kind of talked about, not just issues about the actual nuts and bolts of coverage and reimbursement, but also issues surrounding broadband access, which is, I think, an issue that's becoming more and more important as we have conversations with regards to kind of the ubiquity and necessity of telehealth moving forward. As you can see here, this is just a list of the coalition members right now. I think we have more than 40 coalition members, a lot of provider organizations, many people from consumer organizations, a lot of companies that have moved into Massachusetts or are presently in Massachusetts, or even some companies that are located outside of Massachusetts that have all been members of our coalition. We have folks from the reproductive health community. We have folks that are members of some of our hospitals. We have a lot of rural hospitals that specifically have asked to be members of the coalition and sign on as members of the coalition. And we are very flexible in terms of how folks want to engage and join us in advocacy and information and education and sharing of ideas in terms of the projects that and everything that we've worked on here. One thing that I think Ronnie kind of pointed out that's really important is in Massachusetts, most of the telehealth pre-pandemic was really covered through grant funding. We did have a very limited telehealth law that was passed back in 2012 that allowed for some commercial insurance to provide telehealth services, but only through insurer-approved telehealth networks. So that's kind of been the field that we've been playing on. And you can see right here that since 2012, that was the one piece that we've been working for. Secondly, we didn't really see any engagement from the Mass Health program here in Massachusetts until January of 2019. But when we did, Mass Health has been very active and aggressive, and particularly they started to cover and reimburse for behavioral health services. That was the one piece where the state's Medicaid program started to kind of engage moving forward. And what our coalition really pushed for and advocated for with our state legislators pre-pandemic were three major policy issues at the state level. One was coverage parity for all payers, including the State Employee Group Insurance Commission and Mass Health. Massachusetts has not had coverage parity for telehealth services pre-pandemic. And I think that's a point that kind of, Massachusetts, we tend to think of ourselves as an innovation state. However, we were really far behind in terms of putting in place a regulatory framework for the coverage and reimbursement of telehealth services. Secondly, we wanted to make sure that we instituted proxy credentialing here in Massachusetts to reduce the paperwork burden associated with providing telehealth. We felt that was really important. We wanted to make sure that if there were a lot of provider-to-provider consults coming from a number of our major academic medical centers to our community hospitals, some of whom are 2 or 3 hours away from Boston, that they were able to do so, and we could have an oncologist at, say, the Dana-Farber Cancer Institute who was providing care to a patient at, say, Berkshire Medical Center in Pittsfield in the western part of the state. And that oncologist, she would be able to have a full credentialing review, and that the proxy credential would kind of serve as that one-page attestation under the pains and penalties of perjury that clinician is who she says she is, and she can provide that care to that patient by way of telehealth to those patients out in the western part of the state. So critically important piece. And then finally, the last piece that we always like to talk about that's really important is how we define telehealth here in Massachusetts. And we know this is going to be an ongoing conversation moving forward. We're engaging with our state agencies right now in terms of how we define the services and what telehealth is. But pre-pandemic, telehealth was, we wanted to seek a flexible and comprehensive definition of telehealth that included both interactive and asynchronous technologies. Interactive was very understandable to a lot of people pre-pandemic. Asynchronous technologies, people didn't have a lot of experience with them pre-pandemic. And then the funny thing is there was really not a lot of advocacy in favor of audio-only telephone. And through this pandemic, we've seen the broad expansion in coverage and reimbursement for audio-only telephone, both at the state level and through Medicare, and for which we're really grateful for all of our patients. So then the pandemic hits. Is this where I hand it over to you, Akriti? I think it is.
I think so.
I think I tag you in here, so I'm gonna let you take over.
Awesome. Thanks, Adam. And good afternoon, everyone. Akriti Bombi here, as was introduced by Nicole over at the Hospital Association. And before I begin briefly, I want to say that the cool privilege I have is that when I worked in the state legislature here in Massachusetts, my office was aligned with a lot of the work that the TMED Coalition was doing. And so it's been a fun transition to right during pandemic, switch over to the Hospital Association, and now joined in with Adam on the coalition. So kind of we'll speak to a little bit of both sides of that life. But very quickly, as Adam mentioned, and I think Ronnie alluded to as well, the pandemic was really the crux of movement in the state here in terms of pushing legislation to really establish a framework for telehealth. And this all, and I'll speak to the legislation in a second, but really what happened first is a series of very quick executive orders that came out across the state. And I think all of us experience those in various ways, but executive orders really to start requiring the coverage and reimbursement, particularly of telehealth services across the state during the pandemic, and importantly, during the pandemic, that reimbursement level being on parity with in-person services, which is a theme that comes up a lot in our presentation today. And so the governor's office, Mass Health, and then and thanks to some lobbying, certainly at the federal level, getting a lot of coverage, protection, reimbursement of telehealth services. A big victory we got was sort of, I want to say during the summer of 2020 was the coverage of audio only from CMS, and that was fantastic, and really was thanks to a lot of advocacy from folks and spokesperson on behalf of rural communities, certainly as Ronnie mentioned, and folks who are from an equity perspective, older patients or those who may not have technological literacy to utilize video technology. So it was a great victory. And so the long story long here is that Massachusetts patients really have readily adopted telehealth. And that's an important lesson to take away from the pandemic as the slide indicates, we were one of the highest utilizers of telehealth in the initial surge, and particularly in the behavioral health space. It's been an amazing resource for folks. So that's kind of the general broad strokes of the pandemic. And then, and as I said, also a big legislative victory, and kudos again, truly to the TMED Coalition. It was a lesson fought, after years of work. So on January 1st of 2020, a very happy new year, Massachusetts rang in its statewide permanent telehealth structure. And so to kind of reflect the points that Adam had mentioned earlier, the law does include coverage for all telehealth services. It does include pieces around proxy credentialing, and it has a very, very welcome flexible definition of telehealth. So synchronous, asynchronous, and even audio only at the state level. And the bill was drafted interestingly, or passed as its final version interestingly. So it tiers out some of the medical services provided. So the hugest win we have to bring to you all today is that in the state of Massachusetts in perpetuity, patients seeking behavioral health services will be able to receive telehealth services, and providers will get their services reimbursed on par with in-person visits in perpetuity, which is a great victory. And it's a very expansive bucket. The two other buckets that the law touches on are primary care and chronic disease management. Those are treated a little bit differently in the law. So for the next 2 years, chronic disease management and primary care services will be reimbursed on par with in-person visits via telehealth. And as Adam mentioned, some of the advocacy that we're doing with our state agencies is really, it's interesting for those who like to nerd out on this, but really definitional stuff, right? So the nuts and bolts of what is primary care, who are the providers that offer it, what does chronic disease management mean? What are the chronic diseases that are covered? So these are some of and also even frankly, the notion of what a telehealth visit or encounter is. So these are some of the more philosophical questions that we're thinking through in conjunction with Mass Health here in Massachusetts, Massachusetts and our state Medicaid program and our division of insurance as well. So it's been a robust year and a half for telehealth here in the state. And then finally, would love to hear Adam's perspectives as well in this part, but this is one of my favorite pieces, is just kind of talking through in a couple of minutes, just a little bit of the sort of background of the advocacy piece, which is where my beating heart lies. And I'll pass the mic over to Adam in a second to give kind of the history of the advocacy piece, but I'll speak to my experiences quickly with a couple of short examples. So at least in the context of our telehealth law, a few big lessons that I've taken away, both having worked inside the building and now outside of it. Diverse coalitions matter, diverse voices matter, and I mean that is in the broadest way possible. So I think one of the TMED Coalition's greatest strengths is, as Adam mentioned, it's over 40 folks, and they're not just policy wonks, right? They're not just government affairs folks, they're providers. They are advocates on behalf of communities of color, the elderly, kids. They're also folks who represent like broadband, right? And tech. And so one of the great strengths that I think the coalition brings is that the legislation that comes out of it, and we filed a new piece at Telehealth 2.0, centering equity, is that our legislation is sort of like pre-vetted. And so the stakeholders who'd be at the table at the final day when the bill's on the floor are kind of already in the room to begin. So we feel like that puts our best foot forward in terms of negotiation, kind of takes all the voices in. The other piece that the coalition really centers is narrative as part of advocacy. And so you'll see there, you've got to tell a good story. I can't tell you how important that is. And really it speaks to numbers are important, right? And I think that a good story doesn't lack numbers, but there's something about the face behind the number. And so to say something like Massachusetts, one of the state highest utilizers of telehealth nationally, that statement resonates here, right? Because it indicates to the policymakers here, okay, we have to prioritize it. And by prioritize, it means we've got to invest in it, which is the big kicker, right? So how to invest policymakers to not only craft legislation, but then fund it if necessary, right? And then I'll just say one other piece is when partnering with the policymakers that we do in terms of pushing our advocacy, choosing the right ones is a really, really big lesson we learned. So to give some kudos to my former boss, we had been working, like I said, with the coalition on the legislation from inside the building. And she very notably, it'll go down in her record, she held up debate on the bill in the House because she was insistent upon lifting what was initially in the draft, a requirement to first have an in-person check-in with your provider prior to prescribing. And she was very committed to lifting that requirement. And so she stormed right into the majority leader's office and held up session and insisted that it be removed and was equipped, and you'll see this too, you've got to be good educators, equipped with the right information and the most compelling information to convince leadership that this was actually an important thing to lift. And so it was lifted in the final law. So I say that to say it was a really great constellation of finding the right person who's going to fight for your stuff, great communication between the advocacy coalition and that legislator, and also equipping them with the right kind of talking points and narrative to really shift hearts and minds on the twist or jump of a dime, turn of a dime, flip of a dime. So I'll pass the mic back to Adam to add some more color, and grateful for your time and listening.
Thank you. And yeah, and you know, to bring it to the rural level, importantly, our biggest advocates were our rural hospitals, right? Our rural hospitals were the biggest utilizers of telehealth pre-pandemic. In particular, some of our hospitals in North Central Massachusetts were running a telebehavioral health grant program with their local middle and high schools, and they were bringing teletherapy services with licensed mental health counselors who were located in the community, but they had their students working with a community health worker inside the school to be able to access telehealth services. And we brought them to the State House and we did demonstrations with their legislators in the State House, and their providers were located remotely, and we did mock sessions to kind of show, and we actually brought in students from the high school to show and kind of give the legislators a flavor of what an actual teletherapy session would look like, and that really was really good in terms of the hands-on education component in all of this, and our rural providers were so so involved in that and so committed to continuing that and to really providing the education piece and really holding folks' hands, holding policymakers' hands to get them to understand kind of what the challenges were, but kind of what the benefits could potentially be, and to be able to see that, you know, that productivity would increase by keeping parents at work and keeping those kids at school. You know, another story I'll tell just briefly is we had one student who commuted in from the central part of the state and had a very rare form of oral Crohn's disease, but he missed 45 days of school to come in every time he had a flare up. And if he had had the opportunity to be able to provide and access telehealth services, you know, he wouldn't have missed those days of school. He could have received that care, you know, at his home, in his community, or even, you know, potentially in a conference room at his school, you know, to be able to get the care that he needed, because it was only really, kind of a 15 or 20 minute evaluation and an appointment. However, he had to come in all the way into Boston, you know, and pay tolls, pay for parking. I hate to kind of reiterate this point, but pay for tolls, pay for parking, pay for gas, pay for lunch, you know, and his mom had to take all that time out of school to bring him in every time he had one of these flare-ups. And telehealth is, and he was such a big and great advocate for us to be able to kind of provide that care. And another example of somebody coming from the rural part of Massachusetts to kind of engage in that conversation was so critically important in all of this. So I think it's time for me to hand off the baton so we can give some time to our folks who joined us here from Florida today. So we'd be happy to take any questions at the end of today's session.
That sounds good. Thanks so much. If you have questions for our Massachusetts folks, please feel free to put them in the chat and they can address them as Lela and Abbie start talking. And then if we have a minute or two at the end, we will go ahead and take them verbally. But for right now, go ahead and drop them in the chat and we can address them that way. Lela and Abbie, I'll turn it over to you.
Okay, great. I'm sharing my screen. Are you all okay? Yep. I see thumbs up. Thank you so much. This is the first time I've done it with this platform, so I apologize in advance if there's some bumps in the road, but thanks so much. My name is Lela Shepard. I am the director for the Office of Rural Health here in Florida. And I thought it's very interesting. I didn't know until this afternoon exactly what Massachusetts telehealth presentation was going to be about, but I find it very interesting because you know, here we were just heard about the policy and advocacy efforts of a statewide telehealth coalition, and we're going to totally pivot kind of an opposite direction because what I'm going to outline is what we did with some no-cost extension funds and carryover funds to purchase a tool for our critical access hospitals and their rural EMS agencies. So it's getting quite a range here. So it's very interesting. I hope someday we have a telehealth coalition that has done all that you all have done. I mean, we've got one, but it's doing great things, but it was great to hear what you guys have done. Okay, so go to the next slide. All right, you all see the next slide, Office of Rural Health and our staff. Okay, good. So I was thinking before the presentation about what Tori said and others from HRSA said the first day of the reverse site visit. And that was about quality in the FLEX program and the focus that it's a journey, not a destination. And a strong foundation is the key to success. And I definitely think our experience this year with trying to leverage some funds that weren't used prior to myself and Abbie joining 2 years ago, that is very true with our experience. And I'll be outlining some of that today. But I first wanted to focus on one of those keys to success. You know, for us, we had to focus on our foundation. We had to add some staff to our Office of Rural Health. And I just put up here a slide of the folks that are part of the staff, but we also created some new positions. We needed some help in the Office of Rural Health with all that we had to do for our rural hospitals and their communities. And we just hired our last new position or staff person for the new position, Kim Rita. And we're really excited because we're fully staffed at the moment and ready to move forward. But that foundation was key. And the other key, let me just go to the next slide. So I also thought every Office of Rural Health is different. So I wanted to just briefly touch upon what the Office of Rural Health in Florida looks like. First off, the Office of Rural Health is in the Florida Department of Health. In Florida, we have two health agencies. We have the Department of Health, and then we have an agency for healthcare administration, otherwise known as AHCA. So in Florida, the Department of Health licenses physicians, clinical, nurses, other clinical professions. But the AHCA, the Agency for Healthcare Administration, they actually license clinics, rural health clinics in hospitals, and of course our critical access hospitals. So the Office of Rural Health here at the Department of Health, we administer, of course, Flex and SHIP and the SOAR grant. We also get some state funding, and we manage 22 contracts and roughly around 32 purchase orders this year. Now, those are being reduced this year. We try to change some things so that the amount of contracts and purchase orders we're managing is reduced. We also, like most of the SOAR offices, we are distributing the CARES and ARPA SHIP COVID-19 funds to hospitals. And then we're also involved in the CDC COVID-19 Health Disparities Grant. We did put in a proposal that gives our rural health networks additional funding to work with our CAHs on population health issues. So we're looking forward to that as well. And then when my Flex coordinator and I came on board in 2019, we did have a lot of carryover funds and no cost extension funds. And so when COVID hit, that's the pot of funding we used to address a telehealth, telemedicine need for our CAHs and rural EMS agencies. So initially with this telehealth project, we learned from our EMS folks. We work very closely with another bureau here. The Office of Rural Health works with the Bureau of Emergency Medical Operations, and the staff from that bureau was heavily involved in the COVID-19 response in leadership positions. And we started hearing from them that our small rural hospitals and our rural EMS agencies were really having a hard time with dealing with COVID patients coming into the emergency departments and being able to manage those patients. After talking with our leadership about this, we decided to go ahead and use some of our no cost extension flex funds from the 17-18 grant year to purchase telehealth platforms. These platforms come from a company called General Devices. The platform is called eBridge, and it's used in a lot of different hospitals on the East Coast mainly, but they are in a lot of big hospitals, some small rural hospitals, but not a lot. And this project, I think, was one of the first projects where they were really pushing out the platform into several small rural hospitals. So that was a new thing for them. So that was the initial goal, was to help our critical access hospitals and the rural EMS agencies with management and identification of COVID patients. Now, I have to say the initial response we got from our critical access hospitals, they were very excited. They were excited that our office was possibly giving them a tool they could use, quickly use. And so we went through the process here, got those platforms out to the critical access hospitals. And initially, two of the hospitals accepted the platform. We have, first off, we have 10 hospitals, critical access hospitals in Florida. 2 of them accepted it right away and received the training and started using it. However, 3 of our 10 are part of a hospital system. The 2 in the Keys, Fishermen's and Mariners, and also 1 hospital in West Central Florida that's part of Advent. They rejected it outright, mostly because of the IT requirements and complications that might occur with working with a bigger hospital system. But then it stalled. And this is where I go back to, it's a journey and a learning experience. So let me go back a little bit and give you a little bit of the timeline. So we got approval from our Flex program officer in August of 2020 to use our funds in this way to purchase these platforms for our CAHs and our rural EMS agencies. Florida has some different processes here. We had to then get approval from the legislature to actually use the grant funds in this way and have the ability to spend the money. We didn't receive approval for that until November. So if you're thinking about COVID and what's going on, of course, we had another surge in the winter of COVID. And it was at that time we were able to get 2 platforms into 2 of our CAHs, but then it stalled. Then come February, the vaccine rollout, and we just our hospitals were just too busy. All of our facilities, any kind, if you're in health, everybody was way too busy to think about, especially something like IT. So one of the things that we did is we learned from talking with our critical access hospitals that, they just didn't, quite frankly, have the bandwidth to understand all that the platform did and all the IT needs, even though we provided presentations and trainings and one-on-one technical assistance with critical access hospital leadership, and if they had an IT person working with them, but it's still, given these small hospitals and all that they had to do, it was really quite a bit for them. So our office, come March, we still only had 4 critical access hospitals that accepted the platform. And we had 10 critical access hospitals. We still had 6 that we needed to place the platforms within, or the rural EMS agencies. So one of the things that we did was we engaged a nonprofit called Community Health IT and Kendra Seiler Marsiglio, her organization, because one of the things that we learned, Abbie and myself, one of the things we learned is that we, quite frankly, didn't have the expertise or the bandwidth or understanding of telehealth and all the different IT needs that our hospitals would need. Our vendors, of course, understood the IT needs of most hospitals, but they really hadn't worked with a lot of rural hospitals and what it really takes to work with some of these hospitals to get them what they need. So Community Health IT, they have worked in rural health for years, and we engaged their expertise to help us place those platforms into the critical access hospitals and EMS agencies. And I can say that as of June 30th, we did get those platforms placed into the facilities. And one of the things that we did in terms of changing our goals of this project, we decided that the hospitals, and as COVID has changed, the hospitals are going to need to also learn how to leverage that tool in other ways, not just for their emergency departments. So Community Health IT is engaged in working with each of the critical access hospitals and doing an assessment of their telehealth and telemedicine needs. And then we're going to work with them through the end of December to determine what those are and try to meet those through the coming year.
Is that it for you, Lela? We've got about 1 minute to wrap up. We're at the end of our
Okay.
time.
Okay, I think that's it.
All right.
Thank you.
Yeah, thank you guys so much. Just really quick, what I'd like to point out, fantastic initiatives on both sides. Lela talking about how their project changed and that sort of thing, like that's super common with flex initiatives. You have a plan in the beginning and for whatever reason it doesn't work out, whether you have a global pandemic that drops out of the sky that nobody was really expecting, or hospital engagement just doesn't happen, which is extremely common in flex activities. And then having the ability to turn and adjust as you need to. FRHP loves that. The project officers love it when flex coordinators, well, you know, they don't love it when they hear, oh, this isn't working out, but they do love it when the flex programs come to them when there is a problem and figure out really quick what else they could do instead, so that activities keep happening, improvement keeps happening, and the funds keep moving. So that is just a little something to point out, other than all the amazing accomplishments in telehealth that happened here. So thank you all for taking the time. I'm gonna just put in the chat my email address in case any of the participants had questions they would have liked to have asked the speakers. Feel free to send it to my email address and I will connect you directly with the speakers so you could have more of a conversation. And then, so right now we have a 15-minute break. We'll reconvene at, my document, we'll reconvene at 2:40 Central Time for the final keynote session of Joe Tai of Values Coach, Building a Culture of Ownership in a Post-Pandemic World. To attend this session, you'll need to return to the attendee hub via the link I just pasted in the chat. And if at any time you need to step away or lose connection, please note you can always return to the attendee hub to access the live session at any time. And that is it. So I will see you guys there. Thanks.
Thank you.
Bye, guys.